Welcome back to the deep dive, where we take your sources and give you that ultimate shortcut to being well informed. Today, we are mapping the territory of a truly invisible invader, non-tuberculous mycobacteria, or NTM. This is a group of organisms that is really changing how we think about chronic lung disease.
It really is. And what's so fascinating is just how ubiquitous they are. These are environmental organisms. I mean, they're in the soil, in the water, even in fish and birds. There are over 200 species, and this is key. They are completely distinct from Mycobacterium tuberculosis, the one that causes contagious TB.
That distinction is so critical because, unlike TB, NTM can just sort of live in your respiratory system without causing any symptoms at all. But when it does decide to become a disease, the consequences can be pretty devastating. And the problem is the global prevalence of this NTM pulmonary disease is, well, it's significantly on the rise.
It is. The rise is dominated primarily by something called Mycobacterium avium complex, or MAC for short. And while NTM isn't generally contagious, you're not going to catch it from the person sitting next to you, the fact that it's everywhere means exposure is constant.
And that makes tracking its true scale really difficult, right? I saw that reporting isn't even mandatory in places like the United States, but the data we do have confirms this trend. I mean, there were numbers from a claims database showing the prevalence just shot up, something like from 6.78 to almost 12 per 100,000 people in just 7 years. It's not a rare disease anymore.
Not at all. Clinicians are seeing it more and more.
Yeah.
And they have to grapple with this indolent, meaning, slow developing but often progressive course.
Yeah.
And because the severity varies so widely, diagnosis is really complex. The current clinical guidelines are incredibly strict. You need symptoms, you need positive cultures from the lab, and you need specific imaging findings.
And that is our mission for this deep dive, to understand those specific radiographic features, the critical visual roadmap that pulmonologists need to manage this illness.
Okay, so let's jump in with the most common pattern. It's often called the non-classic phenotype, nodular bronchiectatic NTM.
So tell us about the typical person who shows up with this form. I've heard the profile is quite distinct.
It really is. The classic profile is often described as elderly white women who are often tall and have a low body mass index. They might also have other things going on, like gastroesophageal reflux disease, or even chest wall issues like scoliosis or pectus excavatum.
Wait a minute, hang on. Why height and low BMI? That just doesn't sound intuitive for a lung disease. Is there a theory on that link?
There is, yeah. And while it's not 100% proven, the leading theory is all about impaired mucus clearance. In tall, thin individuals, there might be these subtle, kind of restrictive mechanical issues in the chest that make it harder for the bronchi to clear out secretions. And that lack of clearance, that stagnation, it creates the perfect breeding ground for environmental bacteria like MRT to just take hold.
That makes a lot of sense, like stagnant water. So when the infection does take hold, what's the undeniable signature we see on a CT scan?
The absolute key feature is something called bronchiectasis. It's irreversible abnormal bronchial dilatation. We actually measure it. We look at the bronchus to adjacent pulmonary artery ratio. If that ratio is 1.3 or higher, that airway is officially abnormally dilated.
Okay, so that's for the radiology report. But for those of us trying to visualize it, what's the easy analogy? The one that tells you instantly what you're looking at.
We call it the signet ring sign. Imagine a signet ring, right? You have the large dilated ring shape, that's the bronchus lying right next to the small normal-sized dot of the blood vessel. That specific pairing is the hallmark.
And beyond just the dilation, the bacteria causes a lot of airway inflammation. So what other visual cues are there?
We see bronchial wall thickening, which is inflammation of the pipe itself, and also mucoid impaction, which is basically mucus plugging up the smaller airways.
Which brings us to that other unforgettable visual signature. The one that sounds like it's straight out of a botanical textbook, the tree in bud nodules.
That's it exactly. That pattern is so incredibly distinct. It represents these tiny little central lobular nodules that branch out linearly. They look just like a budding tree branch. And that appearance is the visual result of that distal impaction. The mucus and the bacteria are literally plugging the very ends of the small airways.
And where in the lungs does this form like to set up shop? Is it random?
No, it has a very strong preference for the right middle lobe and the lingula, which is sort of the anatomical equivalent on the left side. It can become diffuse over time, but it usually starts in those gravity-dependent areas, probably because of poor drainage there.
Okay, so we've established this form is often slow, but it's progressive. How does the disease start driving itself forward? How does it become this self-perpetuating chronic illness?
This is where it gets really interesting, and it's summed up by what we call Cole's vicious cycle. So think of the airways as a city's drainage system. The chronic inflammation and the damage, the bronchiectasis, it causes the body to send in its own cleanup crew, the neutrophils.
Right, the immune system's first responders.
Exactly. But these neutrophils, while they're trying to fight the bacteria, they release these incredibly powerful enzymes, proteases, that are highly destructive. And instead of just killing the bacteria, these enzymes start eating away at the airway tissue itself. It's like a maintenance crew that starts eroding the walls of the tunnels they're supposed to be cleaning.
Wow. So the body's attempt to clear the infection actually makes things worse. It causes more dilation, worse ciliary function, and therefore even worse clearance, which just guarantees the NTM stays put and thrives. It's like a tragedy of immunology.
It's a perfect, self-perpetuating, progressively destructive loop.
Now, let's pivot to the pattern that does not follow that slow, indolent course. The classic fibrocavitary NTM.
Okay, this one sounds much more severe just from the name. It is. This is less common than the nodular bronchiectatic form, but it carries a much, much worse prognosis. It has the highest mortality rate among NTM patients.
So the patient profile must be a complete contrast to the tall, thin woman we just talked about.
A stark contrast, yeah. This is typically seen in middle-aged or older individuals, often men, who usually have significant underlying chronic lung destruction already. We're talking about patients with severe COPD or scarring from prior tuberculosis, silicosis, or people who are significantly immunosuppressed.
So pre-existing damage just lets the NTM run wild. What are the signature imaging findings here?
This form is all about the upper lobes. It's upper lobe predominant disease. We look for cavitary nodules and fibronodular opacities, which means scar tissue is already forming. We also commonly see things like pleural thickening and pericicatricial emphysema, which is air sac destruction, right next to all that scarring.
That pattern upper lobes, consolidation, cavitation, that sounds like the textbook image of active tuberculosis.
And that's the absolute crucial differential diagnosis. Classic NTM is a primary mimic of active Mycobacterium tuberculosis, MTB. Without knowing the culture results, a radiologist looking at this pattern could very easily mistake it for TB.
Is there any way to tell them apart just from the scan?
There are subtle clues, maybe. MTB cavities sometimes have thicker walls, for instance, but honestly, the imaging overlap is just substantial. And this is why the guidelines are so clear. Microbial confirmation from the lab is absolutely mandatory. You cannot treat one based on an image that could be the other.
Which brings us to the really difficult clinical part. Deciding to treat. I mean, treatment for NTM is this intense regimen, right? 3 or more drugs for 12 to 18 months after cultures turn negative. It's a huge commitment.
It's a profound decision, and it often involves some pretty toxic medications. The pulmonologist is really relying on the imaging expert to provide critical data before they commit a patient to that regimen. We have to assess severity, track stability, and look for any acute complications.
So how do you describe severity? Is it more than just saying bronchiectasis is present?
It has to be. While it's tough, we have to provide a subjective assessment. Mild, moderate, or severe. And that's based on quantifying the amount of damage. You know, the degree of the bronchiectasis, how thick the walls are, how much mucus plugging there is, and how many of the 5 lobes are involved. We have to document that clearly over time.
And tracking that over years must be incredibly difficult. What defines stability versus something that's actively getting worse?
So stability is when the scan doesn't change much. But what we really have to look out for is something we call waxing and waning disease. This is where those inflammatory nodules and impaction plugs might spontaneously get a bit better, only to worsen again a few months later. It's very common in chronic inflammation.
So the disease is kind of waving at you, but not necessarily gaining ground.
Exactly. The real red flag, the sign that treatment is probably needed right away, is relentlessly progressive disease. That means increasing bronchiectasis, more widespread mucoid impaction, or the development of air trapping. What we see is mosaic attenuation that just gets worse and worse over serial scans. That's the disease actively destroying lung in real time.
And what are the acute, life-threatening complications that demand immediate attention?
The first one is the development of a cavity. If cavitation suddenly appears in that typically slow-moving nodular bronchiectatic form, it signals an immediate shift to a much more aggressive course. And that patient needs potent drugs, like an intravenous aminoglycoside, right away.
And the second major emergency, you mentioned bronchopleural fistulae, or BPF. What exactly is a BPF, and why is it such an emergency?
So a BPF is a connection between an airway and the pleural space, the lining around the lung. It usually happens when a cavity in the lung just ruptures. It creates a hole, an alveolar pleural fistulization. This instantly introduces air into the chest cavity, causing a pneumothorax, a collapsed lung, and often the infection itself spills out too.
So the patient's lung collapses because the cavity literally broke open.
Precisely. We've seen patients develop these years apart on different sides of their lungs. They are severe events that show the relentless destructive power of the infection, and they often require major surgery, like a lobectomy, to manage.
Okay, let's move to the section on hidden threats. This chronic damage must create a complex, scarred background where other things can hide. Let's start with superimposed infections.
Yeah, the NTM damaged airways are highly vulnerable. We frequently see common bacterial or viral pneumonias on top of everything else. For the radiologist, this means looking for a new focal consolidation, a distinct new area of opacification that really stands out against all the chronic known NTM changes. If it's a pseudomonal or streptococcal pneumonia, that patient needs targeted antibiotics immediately.
What about fungal complications?
We look for two main things, both involving Aspergillus. First is allergic bronchopulmonary aspergillosis, or ABPA. This happens when Aspergillus colonizes the already bronchiectatic airways. The key imaging clue here is extensive mucoid impaction, specifically with something called high attenuation mucus, or HAM.
Why high attenuation? What makes it stand out?
High attenuation means it looks brighter white on the scan than normal mucus does. This is because the fungal debris and the intense inflammation cause the mucus to have things like calcium or trace metals in it. HAM is pathognomonic if you see it. It's ABPA. It's a critical finding.
And the other fungal issue is the aspergilloma.
Yes, that's a classic fungus ball. It's a mass of fungus, fibrin, and cellular debris that settles into a pre-existing cavity left by prior NTM or TB. It creates the classic air crescent sign on imaging, where you see this mass separated from the cavity wall by a little sliver of air.
Now, for what sounds like a most high-stakes distinction of all, telling inflammation apart from malignancy. Chronic inflammatory disease is notorious for hiding or mimicking lung cancer.
This is a massive, massive challenge. We established that inflammatory nodules from NTM will usually regress or, and this is crucial, they wax and wane over time. They're dynamic. Malignancy, on the other hand, should be suspected if you have a fixed progressive lesion, a nodule or a mass that is just showing increasing size or increasing density over time.
And we have to remember the case you shared. A subsolid opacity, initially just assumed to be a stable scar from NTM, but because it slowly increased in size and solid component density, it was biopsied. And it turned out to be invasive adenocarcinoma.
That case is a constant reminder for us. In the presence of all this chronic disease, you cannot become complacent about small, fixed lesions. The pulmonologist is counting on the radiologist to track these things over years, distinguishing the waving inflammatory lesions from the fixed growing ones that might be cancer.
Okay, before we wrap up, a few less common but very specific NTM manifestations, starting with the great name, hot tub lung.
Yes. This is a truly unique one. Hot tub lung is a form of hypersensitivity pneumonitis. It's from inhaling aerosolized NTM from contaminated water sources, hot tubs, saunas, indoor pools. It's more of an allergic response, not just a simple infection.
And the imaging reflects that allergic picture.
Right, exactly. The imaging features are usually these centrilobular ground glass nodules and mosaic attenuation, which signifies air trapping. It tends to favor the upper lungs because that's where inhaled particles settle best.
And finally, NTM in immunocompromised patients, where the imaging pattern depends heavily on how suppressed the immune system is.
That's right. In advanced HIV/AIDS, NTM usually occurs with very low CD4 counts, under 100. It's often part of a disseminated body-wide infection. The imaging is dominated by extensive lymphadenopathy, swollen glands in the chest, and you rarely see cavities because the immune system is just too weak to form that kind of inflammatory response.
But if the patient is immunocompromised for other reasons, say post-transplant or they're on a TNF inhibitor, the pattern changes completely.
Yes. In those cases, the patient has a less severely impaired immune response. They can still mount an inflammatory reaction, which means cavitary nodules become a common, expected finding, much more similar to that aggressive classic form we discussed earlier.
So, synthesizing everything we've covered, what is the single most important action item for the radiologist who's sending this report to the pulmonologist?
It's the synthesis. It's not just describing what you see. We confirm the imaging diagnosis in the context of the clinical and the lab data. We have to explicitly describe the disease severity, and most importantly, whether the disease is stable, waxing and waning, or relentlessly progressive. And we must always be actively looking for those acute threats, new cavities, BPFs, or any evidence of a malignancy that could be hiding in the background.
The complexity here is just immense because it forces clinicians to manage an infection that's driven not by person-to-person spread, but by our actual environment.
Indeed, it's a fundamental paradigm shift in how we think about chronic disease management.
Which leads us to our final provocative thought for you, the listener. NTM transformed simple environmental exposure into a chronic, long-term disease that requires these intensive multi-drug regimens that can last for years. So, given that these bacteria are literally ubiquitous, they're in our water, in our soil, they're everywhere, what is the ultimate prognosis when the goal of total bacterial elimination is practically impossible? And the therapy itself carries significant risks. It raises some really fundamental questions about how we manage the microbial world that's all around us.
We are constantly inhaling potential pathogens. The focus is really shifting from cure to permanent disease management.
Thank you for navigating this incredible deep dive with us today. Until next time, keep digging deeper.